are going live in 5, 4, 3, 2, 1. We are live.
Okay, so good morning, everyone. A very good morning to all of you. And today we are again back with one more interesting topic, lateral condyle nonunions. And today our guest speaker, just a second. So today our guest speaker is Dr. Vidisha Kulkarni, ma'am from Maharashtra. Ma'am is a expert in deformity correction, adult and complex pediatric trauma, and her interest is hand and upper limb trauma. And she'll be enlightening us towards lateral condyle nonunions. After the talk, we have two very interesting cases by Dr. Sheenam and Dr. Shalin. And then we can ask and we can take all the questions of all the delegates who are present here. We'll try to take as many questions as possible. And the ones which are left, we can ask ma'am separately and share the answers on our fellows group. So without wasting much time, I would invite ma'am to please share her screen and start the talk.
Thank you, Gaurav. Are you able to see?
Yes? Yes, ma'am. Yes, ma'am.
Yes, ma'am.
I first of all thank Dr. Maulin for giving me this opportunity. So as we know that lateral condyle fractures constitute around 17% of fractures of distal humerus. And it is not uncommon to see non-union in these cases. Very often we come across neglected elbow trauma and we see non-union lateral condyles presenting very late, maybe because of missed initial trauma or neglected trauma, or maybe inadequately treated trauma initially. Very often there is progression of the distal articular fragment, especially when it is unstable, Jacob type 3 or 2, progressively displacing proximally or laterally. And when it is not united by 12 weeks, we can consider this as non-union of the lateral condyle. So in Jacob stage 3 or Song stage 5, what happens is the cartilaginous articular surface of the lateral condyle faces the bony surface of humeral metaphysis. So it is almost impossible to achieve union in these kind of fractures with conservative treatment or close reduction, pinning, etc. So usually when the patients present, they are relatively asymptomatic when the fracture is minimally displaced and when there is minimal cubitus valgus deformity. But patients may experience pain or weakness during high performance activities. They may present with or without angular deformity. And when there is progression of Jacob type 3, the mobile fragment tends to migrate proximally and laterally so as to give a valgus deformity. And sometimes in Milch type of 2 fractures, lateral translocation of the proximal radius and ulna, exaggerating the deformity and maybe instability sometimes. So this is how the Milch type 1 fracture gives more of angulation. And when this involves lateral crista of the trochlea, that is Milch type 2, there is angulation as well as translocation of the proximal radius along with the fragment. So this non-union without translocation, because there is intact lateral crista of the trochlea, so the deformity is less. Patients may present with tardy ulnar nerve palsy when there is progression of the cubitus valgus and with more severe deformity. Usually this tardy ulnar palsy is gradual in onset. Gay and Love, in their series of 100 patients of lateral condyle nonunions who presented, they found that the average interval of onset of ulnar palsy was around 20 to 20 years. And this is published in JBJS 1947. Usually the motor loss is first to occur and then the sensory involvement. So treating non-union is a difficult dilemma because patients present at various time intervals. And there are mainly two problems associated. First is the angular deformity, and second is the articular surface opposing the humeral metaphysis. Usually the minor deformities of the cubitus valgus, they are more cosmetic rather than functional. And if surgery is performed to align the distal articular fragment, there is potential risk of osteonecrosis and loss of elbow motion, and which must be considered. So Flynn has devised criteria for treating these cases with modified open reduction. So what are these criteria? If the metaphyseal fragment is large enough, if the displacement of the fracture is less than 1 centimeter from the joint articular surface, and if the lateral condylar physis is open, these non-unions are good candidates for modified open reduction, which involves metaphyseal screw fixation and achieving union at the metaphysis level, maybe with a use of a bone graft in the metaphyseal area, and no attempt is made to align the lateral condyle to the trochlear surface in anatomic way. So another controversy is how much delay after injury is safe for open reduction and internal fixation. There are many schools of thought. One author, Dhillon and colleagues, they feel that it is safe to go for ORIF in patients presenting up to 3 months of injury interval. In other centers, like advocated by Flynn in JBGS, they have done ORIF up to 3 years of late presentations. And in the teens paper, they have mentioned they have done few cases up to 2 years. But many other centers agree that up to 8 to 9 months, it is safe to go for ORIF without complicating the surgery. So in situ fixation of the non-union is recommended because anatomic fixation requires extensive soft tissue stripping for mobilizing the distal articular fragment of the lateral condyle and reducing it with the trochlea. So which may result in devascularization of the lateral condyle, which can lead to avascular necrosis, elbow stiffness, and persistent non-union. There is another study by Wartenberger, which is published in JPO 2002. And he says that it is better to accept malreduction rather than going for anatomic reduction by stripping soft tissues of the lateral condyle to achieve a more congruent reduction. So in his series, he has treated non-unions with greater than 1 centimeter displacement, and the position of the fragment was improved very little by the surgeon. But all non-unions united with reasonably good alignment of the arm. And in his series, no child developed AVN in a 6-year follow. So if we know that at 3 months, we can call the fracture as non-union. So the dilemma is whether to dissect extensively to achieve reduction or do in situ fixation. As we know, if treated conservatively, it may lead to progressive valgus and sometimes tardy ulnar palsy. And so the ORIF should be done carefully. So this is how this patient with lateral condyle non-union was treated with ORIF, and this resulted in avascular necrosis of the lateral condyle. So it is very, very important to do careful soft tissue dissection by keeping the dissection more on the anterior aspect, because the blood supply of the condyle comes from the posterior aspect. So there are 4 treatment options like conservative treatment, but no surgery can have the disadvantage of progression of the valgus deformity, sometimes instability if the valgus angle is severe, and there is always a risk of late onset ulnar nerve palsy. So currently surgery is favored. For milder deformities, it is only a cosmetic problem. Usually the flexion extension arc is maintained, as in this patient who presented 20 years after the initial trauma with this non-union lateral condyle, and he is doing functionally well with little bit pain here and there on heavy activities. So second treatment option is standard ORIF. Third is modified ORIF for late presentations with minimal valgus deformity. And fourth option is in situ fusion with corrective osteotomy for severe valgus deformities. So what are the indications of standard ORIF? So whenever the non-union is less than 9 months duration and with moderate displacement of the fracture fragment and minimal valgus deformity, we can still go for open reduction internal fixation through lateral approach. So this boy, 7-year boy, presented at 3 months with the lateral condyle non-union. This is CT. So through lateral approach, keeping the dissection anteriorly, the fragment was mobilized. It was aligned with the trochlea with a K wire and another K wire to hold it with the metaphysis. And then screw was passed like this. This is the introp picture. And I sometimes take additional vicryl sutures through the extensor origin, and that helps in mobilizing the fragment without much dissection. So mainly dissection is carried out at metaphyseal level, and then the fragment is mobilized with the help of sutures through the extensor origin to align it with the trochlea, and then the fixation is achieved. And this is follow-up, 2-month follow-up and 3-month follow-up of the patient. This is after implant removal, and this is his function. So,
Vidisha,
yeah.
can you come again where you put this vicryl suture and how it helps? Can you come again for that?
Yeah, the vicryl sutures are put through the common extensor origin. And with pulling these sutures, the fragment can be mobilized without extensive dissection. So it is okay when the patient presents less than 6 months or so.
Right.
After that, it is difficult to mobilize the fragment.
Right, got it.
Yeah. So this is how extra articular fixation is achieved. And this is not my case, but in this author series, he has achieved union by doing bone grafting on the metaphyseal area. So now coming to patient's 8-month-old non-union, and standard ORIF we have tried in this patient, and this united. Now modified ORIF, which is reserved for non-unions presenting more than 9 months of duration. It is important to note that the deformity should be mild valgus. So what is the modification against standard ORIF? There is no intra-articular dissection carried out to align the lateral fragment with the medial fragment. So some malunion is accepted. You can add bone graft in the metaphyseal area and put smooth K wires or a compression screw. This boy, a 9-year-old boy, presented with 2-year-old non-union with almost 35 degrees of cubitus valgus deformity. So again with modified ORIF, the metaphyseal compression was achieved with the screw and some bone graft, and this united, although there was some FFD. Now coming to in situ fusion, which is reserved for patients presenting very late and with severe valgus deformity. Sometimes instability may be there, or maybe tardy ulnar nerve palsy may be there. So no attempts are made at all to mobilize the lateral condyle, and in situ fusion is achieved using K-wires or a compression screw and SOS bone graft. And ulnar nerve transfer is controversial. If you are correcting the deformity, then there is no need of anteriorly transposing the ulnar nerve. So originally this is described by tricep splitting approach by Tien. I do it by paratricipital approach, and that minimizes my soft tissue dissection and stiffness in the postoperative period. You can mobilize without much adhesions. So this is how the dome osteotomy is performed. And sometimes medial wedge can be removed and it can be put in the metaphyseal lateral area to enhance healing. So this is a 4-year-old non-union in a 7-year-old boy with almost 45 degrees of cubitus valgus angle, and in situ fusion was done with dome osteotomy with a screw and a K-wire. And this is 6-month follow-up of the patient and 2-year follow-up of the patient with good union. Now coming to another case who presented with 50 degree of cubitus valgus deformity, 5-year-old boy with a 3-year-old non-union, again done with in situ fusion using K-wires and a corrective dome osteotomy. And this united, this is 1-year follow-up of the same patient. Although there is some FFD, there is reasonable flexion achieved. So according to literature, for all severe valgus deformities, along with the dome osteotomy is easy to perform, and there is no need to remove wedge when you go for closing wedge osteotomy medially. So in situ fusion is achieved with either K-wires or a screw. And when you are correcting the deformity, you need not transfer the ulnar nerve anteriorly. In their series, they have achieved satisfactory results in non-unions done up to interval of 5 years. So in conclusion, patients presenting before 3 months, you can call it delayed presentation and you can always go for ORIF. Patients presenting from 3 months up to 8 to 9 months, you can still go for open reduction internal fixation. And for patients presenting more than 1 year up to 3 years, with you can go for modified ORIF with minimal cubitus valgus deformity and accept the malunion. You may do bone grafting in the metaphyseal area. And for patients presenting 3 years onwards till maturity, you can go for a dome osteotomy or any corrective osteotomy to correct the valgus deformity and instability. And you can also go for in situ fusion in these cases. Thank you very much.
Yeah, so Vidisha.
Shall I stop sharing the screen?
Yeah, please. So I must tell you that this is one of the best lectures we have heard in this series. Very precise and very to the point. So it's a fantastic talk. I'm sure the fellows would like to re-listen to it and understand it in greater depth. Only one point I would like to mention and would like to have your opinion. There were few cases where once we correct the valgus by dome osteotomy, instances happened that I fix the lateral condyle with a screw and then start doing flexion, and the flexion is not happening.
Yeah.
What I mean to say is that sometimes when there is trochlear AVN or joint stiffness, the movements are happening from the lateral condyle non-union.
Yeah.
So the moment you remove the wire, there is full movement again. So should we fix that lateral condyle with a screw in that instance, or should we leave it?
Yeah, in 1 or 2 cases, I have inadvertently fixed the lateral condyle while putting the K-wire, and this may result in a fixed flexion contracture, and it is difficult to gain movement to the pre-op level. I agree completely. So try to put screw through the extra articular portion, but in some instances you may achieve fixing of the lateral condyle to the metaphysis, and there may be restriction of movement. So in such cases, go for early rehab at 2
Right.
weeks or so.
So my concern is, like, can we leave now the patients if they are skeletally mature?
Yeah. So yeah.
Can we leave that lateral condyle without
Yeah.
fixation and just correcting the deformity?
So for patients presenting late and older children, you may only correct the deformity.
Yeah.
Yeah.
Okay, Gaurav, over to you for questions, please.
Yeah, so thank you, ma'am, for this wonderful talk. And we have a few questions. So just a second. First question is by Dr. Anil Agarwal from Delhi. When to add bone graft and what bone graft to use?
I have used in 1 or 2 cases bone graft from the iliac crest, but if the child is very young, you need not put bone graft as well, because as we are compressing the metaphyseal fragment, you get union without a bone graft. If the child is older, you may put.
And if at all we are putting, we should use iliac crest bone graft.
Yeah, I have done with that only.
Okay.
Gaurav, one more point, Gaurav.
Yes, sir.
What I have done is, if we are not putting bone graft, then you do multiple small K-wire drill holes on the metaphysis as well as on the epiphysis. So that will lead to the opening of channels, and it helps. There's no literature about it, but that me and Dr. Sandeep Patwardhan, we have been doing this, making some drill holes or some denuding the bit of cortical part, so that helps in bridging talus.
Right.
That's just a small, yeah.
And in cases, if you are going to do dome osteotomy or correctomy, you can put medial bone graft. You can remove a little bit wedge and use the same as a bone graft laterally.
Right. So, okay. Another question is, in things gone wrong, if the lateral condyle fragment is completely denuded, any tips how to manage?
While dissecting, start from supracondylar ridge and keep your dissection mid-axial or anterior to the Cocker's interval. So keep your dissection anterior to the ECU, either through EDC, or so that also you spare the collateral ligament and you remain anteriorly. So the blood supply is not hampered at all. And if you take sutures, you need not dissect more. With the help of sutures, I have found it mobilizing the fragment when the patients are presenting early, it is better.
And then,
So in this manner, you can avoid hampering the blood supply, or posterior dissection is not needed.
he's saying if by mistake it has got denuded.
So then wait and watch.
Right. Okay. So one of my questions is, while opening and doing the modified ORIF, we are trying to align the fragment metaphysically.
Yeah.
And we are not doing much of intra-articular dissection. So when we are opening the fragment and then we are opening the fracture site metaphysically, what is the step where we have to stop and consider that as our final correction and just fix it there? I mean, is there any step where we have to stop?
See, it is important to achieve union in the metaphyseal area. So you have to remove fibrous tissue, callus from the metaphyseal area itself. And you need not go till the physis or epiphysis. So you stop there and achieve compression because the authors have mentioned that accept some malunion.
Okay.
It will not hamper. Only the alignment of the fragment should be good with the humeral shaft.
Okay.
So this is to halt the progression of the deformity.
Right. Fine. So one more question. Yeah, sorry, sir.
So Vidisha, we are doing through the posterior approach. So how would you position the patient laterally, right?
For dome osteotomy, yeah, lateral position.
So now you have templated your correction that this much of dome and this much of translation. How do you decide intraoperatively that this is adequate correction and this is not over virus or over correction? Can you give a tip on that?
The triceps give you guideline. When we are correcting varus deformity, the triceps is on the medial side. And when you get correction, it comes in the center. Similarly, in the valgus deformity, the triceps is more on the lateral side. And when
Okay.
you correct your deformity angle, it will be in the center. And you need very good assistance to hold the dome osteotomy in corrected position, because it is easy to perform dome osteotomy, but it is difficult to maintain the correction.
Right. Now we have been like just transfixing with a temporary K wire.
Yeah.
And with a radiolucent bolster, we try to see the humeral axis and the ulna. That's another way, but this is right. The triceps position would guide us. Yep.
So another question is, in case of late fractures, if it sometimes becomes difficult to recognize the articular surface on the fragment, or the fragment is turned upside down, do you still prefer in situ fixation in these cases, or in case of open reduction, how to recognize the articular surface?
See, if the patient is presenting less than 9 months, you can always go for maximal possible open reduction, not violating the lateral condyle of the soft tissues. So without violation, you can use, as I told, you can use sutures through the extensor origin. You can use a K-wire joystick. Then you pass intercondylar wire from capitulum to the trochlea, and you check it, and then you pass a wire from distal to proximal retrograde manner to engage the metaphysis. So do not aim for exact anatomical reduction if the patients are presenting late and late. And if the patients are older enough, K wires are not sufficient, you may add a plate. If the patient is about 12 or 13-year-old, K wires may not be sufficient.
So, how do you counsel these latecomers? Whenever they come, they are expecting that they get it absolutely cosmetically corrected and with full range of motion at the elbow. So, what is your counseling to them?
It is very, very important to counsel the patient beforehand, the relatives, regarding loss of elbow function. First thing. Second thing is, even if you fix and you get union, there will be a spur formation and there will be some deformity seen. It may be a pseudovarus or what. And third thing is to warn them regarding a vascular necrosis, which may occur in due course. So after proper counseling, you can go for surgery. And you tell them to get deformity correction to halt the progression of the deformity and avoid the risk of tardy ulnar nerve palsy when the valgus angle is more.
Any tips for managing AVN of the lateral condyle?
See, I have not treated any AVN as such. Maybe Maulin, can you add?
No, we can just pray once it happens, So the key thing is to, at the outset, you do good approach, go anteriorly. But again, now for lateral condyle, posterior approach is being taken. No, there are some recent papers. So I don't know what is happening there.
Yeah.
But for years, we have been doing this anterior approach and getting good reduction. So that's the key. And once AVN happens, then just wait and watch. And this might go for arthritic changes and fishtail and limited. So it has a poorer prognosis. So you have to gradually introduce those things to family.
So one question by Dr. Shyam: if we do casting, what are the chances of fracture displacement in the 3rd week of cast?
Conservatively treating?
Yes.
Non-unions.
I mean, she must have asked regarding fresh lateral condyles.
Oh, So I think conservative treatment, you need frequent follow-ups, weekly interval, and see whether the fragment displaces or not. And tell the parents that if the fragment gets displacement, I will do surgery and realign the fragment.
One
But
more question.
Shinam, if you have seen as we do for this borderline cases type 2 casting, we follow every weekly for 2 weeks. For 2 weeks, if it is not displaced in younger children, say average ages are 6-7 years, after 2 weeks it's not gonna move, right? And then you can call them at 4 weeks and 6 weeks, and we know that once a metaphyseal healing happens, then only we'll discontinue the treatment. Yeah.
And one more thing I wanted to add, do not immobilize more than 3 weeks for operated patients, at least. What is your protocol, Maulin?
For I give priority to the union. Like if I have done the dome osteotomy, then we should see some radiologic union. When we have placed the K wires, then I protect them a bit longer. In most of older kids, we put a contoured locking reconstruction plate. And at times we add a neutralization plate for the medial pillar, the lateral pillar also. So there you can start mobilizing earlier. But if the patient is reliable, then you can start guarded mobilization early.
So, sir, for how long sir has gone, I think, yeah. So, fine. So, when he'll be back, we'll ask. So, one more question is, what is your comment on using vascularized humeral periosteal flap to treat non-union?
I have not done any vascularized graft, but heard of some people doing it with satisfactory results. But I cannot comment on this since I have not used this technique.
Right. So, okay. So one last question is, I really liked your last slide where you have concluded by comparing ORIF, modified ORIF and in situ fusion and osteotomy and the timelines. I just wanted to know, do we have good level of evidence or comparative studies about these timings and about these techniques?
Yeah, this picture is from some of the article. I may give you the reference later on.
Right.
Probably this is by T.N. et al.
Okay.
Published in JBGS 2005. But
Okay.
let me check. I will give it to you.
That will be really helpful, ma'am. We will share it on our group also. So thank you, ma'am. Thank you for answering all our questions, and it gave us a lot of clarity on lateral condyle non-unions. I'm sure everybody has been a lot benefited by this talk. And so now I would like Dr. Sheenam to start her case. Dr. Sheenam.
Yes, sir. This four-year-old male child presented to us with deformity at left elbow and bump over left elbow lateral aspect. There was history of trauma to left elbow 1 year back. He underwent plaster applications for 1.5 months. After plaster removal, he underwent physiotherapy. It was his initial X-ray that was treated with plaster application. This was treated with plaster application for 1.5 months. And then after 1.5 months, when they observed deformity, they visited orthopedic surgeon and he get the CT scan done. It revealed old fracture lateral condyle left humerus. These are the CT scan
First of all,
pictures.
Sheena. Hello, can you hear me? Hello?
Yes, sir. Yes.
Can you go to the first X-ray?
Yes, sir.
Go back. Yeah, so Gaurav or Shalin, can you comment? Should we treat it with casting only? This fracture, what type of fracture this is? What sound classification you will put it as? Gaurav, Shalin, or any other fellow if you want to take?
It is songs type 4, 4 or 5 because the lateral condyle is not flipped more and fracture line is going till the physial physis. So it must be of type 4. Sir.
I agree. So the management is either a closed reduction with arthrogram or you have to open it and fix it. But conservative treatment is not a recommended policy for this sort of fracture, right?
Yes, sir.
And that they all are there are a few adult orthopedic colleagues who are part of this webinar. So this sort of picture we should fix it. Now Sheenam, your slide should have only this. See, I cannot see the X-ray very clearly. So your slide should have the full X-ray. The area of interest should be focused with. Fine. Yeah, go ahead with your presentation.
CT scan revealed fracture lateral condyle humerus. We can see metaphyseal plastic deformation and rolled up callus on the metaphyseal edge of the distal fragment, that is collar sign. Metaphyseal displacement is not a surrogate for articular displacement or reduction. This is a coronal picture of the coronal view of the humerus. Now, what should we do in this case? First is we can do observation, in situ fixation, open reduction, internal fixation with or without bone grafting, or only anterior transposition of ulnar nerve and corrective osteotomy.
Can you go back to the CT slide, the last slide?
Yes.
Yeah, Vidisha, this is the 1-year-old in a young child without any ulnar nerve symptoms at this point, with milder deformity or minimal deformity. So, how should we approach this?
Yeah, since this is 1 year duration from trauma, isn't it?
Yes, ma'am.
Yeah. So I will go for modified ORF.
Yeah. But as you said, in most of the literature, they said that after 9 months, the kind of opening would not help much, right? That's what you said in your lecture also.
Yeah.
But as you say, that Jacqueline and the colleagues that they have done till 2 years. So Shinam, show what we did. Like we opted to do in situ fixation percutaneous with a compression screw, and Shinam could show what we did and what happened.
We used a cancellous screw for fixation, and after 1.5 months, patient came with back out of the screws.
So what happened here is I used a screw and a washer, and there was a metaphyseal surfaces were opposing. I thought, let me put a screw across percutaneously and compress it, and that should do the job. 2 weeks after, when the patient came for suture removal, the screw was prominent underneath the skin, and I saw that it has lost the hold from the medial cortex. So, Vidisha, which mistake I did in this planning? What should I have done?
So this was done percutaneously?
Yeah, it was done percutaneously.
So it should have done by open technique, by
Yeah.
slightly removing the freshening of the metaphyseal area, and then putting compression screw, or you can use K wires as well.
Right.
Yeah.
So that was my mistake. I thought that I will be able to compress it with a screw.
And one more tip I wanted to add, you can use the sutures and put a drill hole proximal to the fracture line and take the sutures through the tunnel created in the metaphysis for additional security.
What sutures are non-absorbable suture you use?
No, I use Vicryl, 1 number Vicryl. So that gives additional stability via soft tissues.
That's a
Anchoring
good
of the
idea. And it could open up the metaphyseal blood channels also. That's a good idea. And so then I learned it hard way that there is no shortcut to success. And I'm sure what we did thereafter.
Then we did open reduction using 1 screw and 2 K wires, and drilling was done to stimulate the bone formation.
I'm able to see this X-ray nicely. So you should crop it. All the fellows, when you do a presentation, there are so much of black area which we are not interested in looking at. So उसको हमें zoom in करके बहुत ही focused दिखाना चाहिए, तो जो the viewers हैं उनको अच्छा दिखेगा. Right, Sheena?
Yes.
Yeah, fine, no problem. Show the follow-up images.
So I have a question here. So when you opened it, you did a modified open or you did a proper thorough complete this thing, articular surface also?
Just modified open, Gaurav.
Okay, sir. Okay.
Yeah, just the lateral side open here, and that ripped, and then as I said, we did some small drill holes and TQD so that it could induce the bridging callus, and then added wires. And the screw is not just it's a fully threaded cancellous screw, titanium screw, and with this we could get a good compression.
Okay, sir.
As we put a little bit of fibrosis from the lateral surface, it allowed more compression. Probably I should have done this in the first screw. Yeah, Sheena, go ahead.
This is the follow-up X.
Yeah.
This is the follow-up X-ray. We can see heel fracture.
Right.
And this is a clinical follow-up. We can see he can do, he achieved full range of motion, full flexion and full extension was there.
Very good result, Maulin.
Yeah, fortunately at the end it came out well. Dr. Anil Agrawal is asking whether you use this
Partial.
washer. Washer should be used if you want to get good compression. But from this, I now feel that we must use fully threaded screw because it has good purchase, and just 4 mm CC with partially threaded screw sometimes not have good purchase. So I would resort to fully threaded screw now, and I tend to use washer. Vidisha, what is your take?
Yeah, I agree completely, because full threaded screw will give more stability, because the bone quality is not good usually.
You add a couple of wires and then you
Yeah,
can
I always add 1 or 2 wires.
any comment from anyone?
Hello, sir. This is Chinmay here.
Yeah,
Yes, sir. After open reduction and after removing all the soft tissue and the callus, soft callus, did you try to move the lateral fragment a little bit to align with the metaphysis, or did you just put it in situ the screw?
I till 9 months, 6 to 9 months, and once I open it, I try to push it with my finger
Okay,
If it
sir.
is moving, then I'll do some efforts to mobilize more. But this was kind of, it was pretty stiff.
Okay, sir.
So it's to do a complete opening and removing fibrosis. Just remove the fibrosis on the lateral aspect
Yes, sir.
and then put a screw. That's
Okay.
it. So that I do on till 6 months to 9 months, not. And clinically I check, if there is a little bit of movement, then I do. But if it is glued by and large, then it just compress it, it will unite the lateral pillar and it would avoid further progression of deformity. That's the principle.
Okay, okay, sir. Thank you, sir.
And this was 1 year old, so ज़्यादा उसको किया नहीं.
Okay, sir. Thank you, sir.
Yeah.
Yeah, so very
So you
nice
can
case.
stop sharing your screen so Shalin can present it.
Yeah.
Nicely presented.
So one
So
more
we need
question.
to do arthrogram regularly. Yeah. So Vidisha, do you do arthrogram regularly
Yeah,
for all
for,
this lateral condyle?
For fresh fractures, I do very often. While treating fresh fractures with close reduction pinning especially.
Shinam, you can,
Yes, yes.
and Shalin, please share your screen.
This is, as we know that Dr. Song has been doing close reduction for all his type 4s and 5s. There you definitely should use arthrogram to make sure that this is nicely placed.
Able to share this.
Dr. Vidisha, Shalin is presenting a problem. It's like we still have to manage it.
Okay, okay.
But your lecture was so lucid, we got the idea of what to do. But still, you can comment on it.
Okay,
What,
okay.
Shalin?
It says the host has disabled screen sharing.
Yes, I see. अभी तो शीट से किया था. Rishi, can you allow Shalin to share the screen?
Yes, sir.
Shalin, check it. You should be able to share now.
Yes, sir. Just join.
So although that paper Vidisha mentions that tardy ulnar palsy starts after second decade, we have seen a few patients developing in adolescence 13, 14. This case also showed some ulnar symptoms. And what that paper says that once they correct the deformity, ulnar nerve symptoms disappears by itself.
No, if the patient is having some motor weakness, then the nerve should be mobilized along
Okay.
with correction of the deformity.
But not otherwise.
Otherwise, it is controversial. I rarely transfer the ulnar nerve nowadays when I'm correcting the deformity. It gets relaxed. I do mobilize it till the first motor branch to FCU.
Okay. Yeah, Shalin, we can see your screen. You can start.
So, good morning, everyone, and I'd like to thank Dr. Meet for this presentation and this case. So, it's a 12-year-old boy with a history of fall 4 years ago. was initially managed by a bone setter and came to us 4 years after injury, with the main complaint of deformity at the left elbow and tingling numbness over the ulnar aspect of left hand. On examination, there was valgus deformity, prominent medial condyle, as well as atrophy of the left forearm and the knuckles. So this is the clinical picture showing the evident valgus deformity, about 20 to 25 degree of valgus, and as well as atrophy of the forearm and the ulnar aspect of the palm, as well as the knuckles was there. And the X-ray showed a non-union of the lateral condyle along with a valgus deformity developed because of it. So with this, so to summarize, this child has a ulnar.
Charlie, there is something more than just lateral condyle nonunions and valgus.
And
What is it?
Fistale deformity, which is
Yeah. So Vidisha, how this problem is different than a simple lateral condyle non-union? Or we usually see minimum fistale. Now there is a big fistale.
So there is some growth disturbance, it looks like. Since the duration is 4 years, no, or more. 4 years or more.
It might be a little more also if the patient was not reliable.
So along with some vascular compromise also, there is growth disturbance causing this fistale. And at this situation, nothing can be done to the fistale apart from correcting the deformity and mobilizing the ulnar nerve and waiting for the ulnar nerve to recover. And if the ulnar nerve recovers, then good. Otherwise, you may require to go for tendon transfers.
Right. So, yeah, Shalin, go ahead.
There's some review of literature whether to repair a non-union of the lateral condyle in children, especially in pediatric population where the growth is left. And this paper very well summarizes that union prevents worsening of the valgus with very little risk of AVN, and acceptance of even a non-anatomic reduction avoids the AVN and allows union to happen. And to address the deformity, this paper very well describes the supracondylar dome osteotomy with along with addressing the non-union, where modified ORIF of the lateral condyle by a paratricepital approach is described, and supracondylar dome osteotomy with this figure describing the calculation of the dome, where the center is at the intersection of middle and proximal fragment at just above the olecranon fossa, and the arc is calculated by the point where the perichondrium and the periosteum meets. So, however, they have described, they have mentioned that when after fixation of the lateral condyle, a provisional fixation, if the range of movement decreases after this first step of the provisional fixation, then lateral condyle fixation is to be avoided, and only supracondylar dome osteotomy should be done in these cases. And this paper has described the three-dimensional kinematics of cubitus valgus, wherein actually the arc of rotation changes, which leads to a fixed flexion deformity appearance, where the child can do an extension, but the fixed flexion deformity is still there, and altered arc of axis of the elbow flexion extension occurs, and shows that non-union shows variability in the axis of rotation, but no irregularity in the movement at the actual pseudoarthrosis site. So most of the effect is because of the cubitus valgus, but not because of the pseudoarthrosis. And this is a case series describing triple management, which is ulnar nerve transposition along with addressing the valgus with supracondylar osteotomy, and fixation of the lateral condyle nonunion. And they have got good results with all of these. The nerve symptoms improved, osteotomy in an average of 43 days, and the lateral condyle non-union site also healed with an average of 77 days. and there was no significant range of movement improvement, but there was statistically significant improvement in the elbow score. So they have recommended to address all the three, the ulnar nerve, the lateral condyle, as well as the supracondylar. So for this case, we analyzed the deformity, found the cora, found the midpoint, and the periosteum periconcave site, and then we plan for a supracondylar dome osteotomy, along with fixation of the lateral condyle and fixation of the dome. So that would be the plan for this case, along with an anterior transposition of the ulnar nerve, as Vidisha madam has suggested. Thank you.
Yes, so can you go back to that slide, Shali, just to the last plan slide? The last slide.
Yeah, the planning slide.
Yeah, now, Dr. Vidisha, can you, would you agree with this plan or some micro management tips?
Yeah, the medial pillar distally is not enough to allow long screws.
Yes,
Yeah,
sir.
so small unicortical should be
Yeah.
there.
You can use a locking plate here so that
Yeah.
you can use unicortical screws.
Yeah.
And you can remove medial wedge a little bit and put in the lateral metaphyseal area to augment its fixation, if at all you are trying to fix the extraarticular portion.
So what I have observed that if we want to make the medial epicondyle less prominent, you have to translate, and so your
Yeah.
dome should be more acute on the medial side, so that this cortex will face the medullary canal of the proximal fragment. Otherwise, it would remain prominent on the medial side, is being corrected.
Yeah. Since the cora is lower down and you are correcting at a higher level, you need to translate a bit.
Translate it.
So,
Yes.
so,
So we will do this case and share the images.
so I have a question. Do we need to fix the lateral condyle in this case, or we can leave it as such?
Or we have to fix it, but what I do is we put a K wire first. Now, once we correct the dome osteotomy, I put a thick wire through the lateral condyle and try to mobilize the elbow. If the movement is severely restricted, then it means that this movement is happening from the non-union and not from the joint itself.
Yeah.
If there is only partial restriction of motion, then I will fix it, thinking that there is a capsular contraction which would resolve with the time, and as Dr. Vidisha said, we should start early mobilization. But if in one case that the elbow I could not flex at all once I fixed the lateral condyle, and then I removed the wire and I saw that it is full range up. So in that case I did not fix. As this child is skeletally mature, I don't expect it to further progress further, But that decision should be intraoperative. A minimal restriction of motion, fix it. If it is severely restricted, then leave it.
Yeah.
So if the child is skeletally mature, then why we should take the attempt to even fix it? We are just correcting the deformity. It will not progress. It's already avascular necrosis is already there. I mean, what we are getting by fixing it?
So this is a very good option, that only correcting the deformity and mobilizing the nerve, since the child is skeletally mature. And we are not going to improve the trochlear blood supply or the growth distance. So I think this should be done, corrective osteotomy and mobilization of the nerve.
So younger children, there is still risk that with the medial growth, it could go further. And the relatively lesser duration, there is this 4-5 years elapsed, there will be a kind of fibrous thing which will not allow for this progression. Anyway, so yeah, thank you for your suggestion in this case, and Meet and Shalin, you have nicely presented it and planned it. I'll try to, generate your animation picture on X-ray now. Fine. Any further question or comment before we wind up this session?
So there is a question by Dr. Raman. Do they complain of pain at non-union site later? Any
Usually
experience
don't
with
have
this?
pain, but the cosmetic deformity and at all if they develop tardial issue. So, Gaurav, you can conclude and thank. And this was nice session. I enjoyed it thoroughly.
Yeah, so same here. I really enjoyed this session, and it has given me a lot of new ideas and a lot of new knowledge. It has added to my current understanding of lateral condyle fractures, and I am very sure everyone has learned a lot from this. Thank you very much, Vidisha ma'am, for this enlightening talk. And finally, I would ask Dr. Meet to share these interesting papers which were pointed out in the last case. And I would request Vidisha ma'am to please share that paper, which was her conclusion slide, so we can share it on the.
I will share to Maulin soon, very soon. And
Yes.
thank you, Maulin and Gaurav, for this opportunity.
Thank you, ma'am. Thank you. Thank you, everyone.
Thank you. See you.
Thank you, ma'am. So, Maulin sir, are you there or you've left?